Good evening, everyone. Thank you for joining us today. It feels wonderful to be at an venue event at BIC after all these years of being on online events. Thank you, BIC, for the opportunity to be here for us to present what we have today. I'd like to begin with a personal anecdote. I celebrated my COVID anniversary, so to say, just a few weeks ago. I say celebrated because I'm acutely aware of the amount of privilege and luck that I had, that I got away with it relatively unscathed. But every so often, I'm constantly taken back to that time, and I wonder what happened to people who were not as lucky, not as privileged as me. How many of them were there? What was their situation? Have we done the right thing by them? Have we actually honored their memory, actually, acknowledged their suffering as such? It seems that, all of us around here, I'm sure, have somebody who has suffered through this pandemic. We have all lost someone, dear. At this point, I'd like to actually, offer my commiserations to everybody who has lost somebody. And as individuals, maybe we will pick up from where we left, pick up the pieces and move on. But as a society, what is it that we need to do? What are the lessons we need to take? And how can we make this a little more easy on ourselves? And how can we make the system better so that we are better equipped to handle something close to this? Okay. So we have to do all of this, we have to get to a start point. And that start point is really how many of these people have we lost? Unfortunately for us, the start point itself is mired in controversy. The government has put out data, official COVID-19 data, which gives us a particular number. But there is a large divergence between what the government is saying and what various other sources, the WHO, as well as other scholars have stated. There has been constant back and forth ever since the numbers from the WHO have come out. And in all this, we seem to have lost what we are here for. So what is it we would like to do? Various scholars have used different methodologies, different research methods, different research approaches to come up to their numbers. So what we are trying to do here is to bring the whole thing under perspective, bring one perspective to this thing, to get all of us to answer that, very uncomfortable question. Mihir and his friend Shekhar have used some very, very innovative ways to approach this problem. So through this hour, we will look at a general perspective on what happened, as well as the various perspectives used, and we will get into specifics of Mihir's paper. And all this so that we can face that uncomfortable question, which is how many people actually died. Just to give some context to the whole thing, I'd like us to rewind to March 2020. There was a sudden lockdown announced, and we saw a reverse migration of sorts. And these restrictions went on for a couple of months, and we saw its impact on the economy. The GDP itself, the rate of growth of GDP fell down dramatically. And this is only capturing the formal economy. We are not even capturing the informal economy here. So we as a country have faced enormous, or have actually borne enormous social and economic costs in order to minimize the impact of the pandemic. But all these restrictions, all these things that came into play, did they really help us control COVID deaths as a first point? That's where that's where the start point of this whole conversation is. I'd like to go through the numbers, and then I'll bring Mihir in so that he gives us perspective on all of this. This is official COVID-19 deaths for the top 15 countries, where India is ranked third. This is official COVID-19 deaths per 100,000 population. Okay, we are only at 38 per 100,000 population. So is this a good measure again? That is another question that we need to ask. And how do we fare amongst others in our subcontinent, in our neighborhood? So India is at 38, Sri Lanka is at 77, and so on and so forth. It's not too very different, but yeah, these are the numbers that we have. At this point, I'd like to bring Mihir in, and he will comment on these numbers, and then we'll go forward.
Hello, everyone, and thank you for joining us today. It's a grim topic, but necessary, and through the next hour, we'll be using the word death and number of deaths and very morbid terms like that. And I apologize that a lot of this is of that nature. But given the importance and seriousness of the topic, I believe it's best that we discuss and put some sunlight on it so that we can all face up to the reality, as Suman said. So I just wanted to kind of highlight a couple of points from these graphs. So one is that these are official numbers that each country's government has acknowledged as the number of people who died of COVID in their country. And as you can see, the United States has acknowledged more than 1 million, more than 10 lakh COVID deaths. And India has acknowledged more than 5 lakhs. And the world's nearly the largest country by population, or very close, China, doesn't even figure in the top 15. So I think the first thing we need to recognize is that these are acknowledged deaths, and acknowledged deaths depend on the style of government, the type of capability of data gathering, the health system, and so on and so forth in each country. The fact that China doesn't appear here should give us a little bit of, should raise questions. And partly it is because this is official data, and official data out of China oftentimes has been put into question. And so I would just say that these are official numbers. Each government has its own drawbacks. Each government has its own ways of counting COVID deaths. But the the thing that stands out starkly with respect to India and Indonesia to some extent is that the number of deaths per 1 lakh of population, which kind of gives you the impact in that regard, India stands kind of alone in the top 15. In fact, countries that are similar in economic structure or age structure are actually counting way more deaths. If you, for example, look at a country like Colombia or Peru, for example, their health systems or their economies are definitely not that far ahead or similar to India in some regards. Their health systems are slightly better. They are recording better and so on. So one of the things kind of that stood out is that while the government has continued to maintain that 5.25 lakh number, this is an important perspective that we stand alone among the top 15. So that itself should kind of raise a question in your mind: is this a counting error? Is this something that, or is this something unique to the Indian subcontinent, that people in the Indian subcontinent don't actually suffer from COVID to the extent that people in other parts did? So that was kind of the context setting part.
Yeah, so having given the official counts both ways, we have seen other reports that are giving a far higher number. So the difference is excess. What is excess? What is excess mortality? And why is it really important for us to study excess mortality?
That's actually an excellent question. So I think the first thing we should remember is that cause of death is an important metric. In countries with excellent health systems, a large proportion of deaths, even those that occur at home, are associated with a cause of death that's recorded. Whether that cause of death is an immediate cause like a traffic accident or a heart failure, or while it's a long-term kind of cause like cancer or some other illness, that's recorded much better in certain health systems. In India, it's not recorded as well. But all countries, in some sense, have a system of recording how many people died within that country in any given time period. So excess mortality just literally refers to the fact that in this case, 2020 and 2021 were years that were unlike the years that went before. Previously, up until 2019, there was no pandemic. There was no event that was on a global scale causing people to die that would otherwise have, with minus that infection, those people would not have necessarily died. Some of them would have died of existing causes, but many would not have. So a standard metric in mortality studies is that you compare a baseline, which is the expected mortality, right? So given that deaths is a statistical figure, every country has a life expectancy rate, and every country has a certain share of population that experiences death events in the family in a year, the numbers are steady year over year. People who die of heart attacks in a given country in a year is relatively steady, or people who die of traffic accidents, while there are slow improvements, that number tends to change relatively slowly. So in that sense, each country has an expected baseline mortality. That is the number of deaths one can expect in a given year. For India, for example, the government of India states that that number is between about 80 to 85 lakh Indians that die every year. That's a government number. The United Nations thinks that number is much higher. The United Nations thinks that number is 95 lakhs to about 1 crore. But in either case, that is the expected mortality. That is the number of people that minus COVID would have died in each of 2020 and 2021. The second part of the calculation is the observed mortality, which is the number of actual deaths reported or estimated using various methods. So what that is because we know that a pandemic is taking place during these 2 years, we believe that a greater number of people will likely have died because of the infection, and that is the observed mortality. And excess mortality is simply a subtraction of the two numbers. What that essentially does is it gives us a measure of how much more loss of life was there during the pandemic period. Not all those deaths would be because of COVID, but they were caused in the pandemic-like situation. So in some sense, they are attributable to the existence of the pandemic situation. So that is the kind of the metric we are looking at.
So when you say they are not COVID, but can be attributed to COVID, you mean they did not get health access or things like that?
So precisely, many of us have seen that hospitals were overflowing, health systems were strained beyond capacity, a lot of routine surgeries were postponed, and so on and so forth. So some of that would also lead to mortality that would not have otherwise taken place. A large chunk of the excess mortality, though, could also be attributed to COVID, given the nature of the disease, the respiratory system being affected and so on. But excess is not necessarily all COVID. Some of it is COVID, and some of it is maybe other things that collapsed or that were not available because of the pandemic.
So what is the extent of this, excess mortality?
So there's a lot of different studies out there, but just for ease for the audience, what I've done is put together the numbers that the WHO estimated and lined them up against what each country's government in our neighborhood has said. So for India, that our official number is about 5.25 lakhs. This is from last week. And the WHO's estimate in early May was 47.4 lakhs. So for India, the WHO states that while the government of India says 5.25 lakh people died of COVID in the last 2 years, 1.6 lakhs in 2020 and the remaining in 2021, the difference between 5.25. The WHO estimates that actually 47.4 lakh excess people died, meaning the WHO's calculations, and these are estimations based on data that we'll get into, but they show that 9 times more people died in India than of COVID. So this 47.4 is just the excess number. This is over and above the 80 lakhs that are estimated to die in India every year. So 47.4 is on top of the 80 lakhs a year that would have died. But it's not very unusual. It's, in fact, the WHO's tables show large excess mortality in many countries. In Pakistan, the number is 7.6 times. In Bangladesh, the number is 4.8 times. Even in the US, if I remember right, there's a 10% excess mortality. Even though, or even in Germany or other countries like that, there are positive excess mortality figures. They're not as far off, but almost all countries in the world have some level of excess mortality because of the pandemic situation. And yeah.
Yes. So when we come to, We are talking about methodologies and approaches people have taken. Firstly, talking about the government itself. How did the government arrive? I mean, what is the government's way of arriving at this 5.25 lakh mortality figure that they have?
Right. So I think this is very important to understand because we have the 5.25 lakhs being touted as the official reliable COVID-19 deaths. So each country has specified criteria for which death events are to be classified as attributable to COVID, the cause of death. So the first thing to remember is in India, the official cause of death, which is reported by a doctor or a health expert at the time of death, is only reported in about 22% of all deaths. So a large proportion of deaths take place at home and they are not medically certified. Even some deaths that take place in medical facilities, they are not certified. Only 22% of deaths actually have a cause of death associated with them in a non-pandemic year, right? What that means is for about 78% of Indians that die in a year, we don't know what they died of. We just know that they died. So that's kind of the baseline infrastructure that we have in India. For COVID deaths in particular, the government has set up criteria, and I'm going to kind of give a more loose definition. But essentially, the government wants a death to be certified as COVID death if within the preceding period of death, the Supreme Court also had to rule on it, but for several weeks prior to the death event, if a person had a known COVID infection, either reported through an RT-PCR test or an antigen test, or through a doctor's report of a lung X-ray or other event related to other health abnormality related to COVID, then it is counted as a COVID death. So important to remember that one needs an RT-PCR or an antigen test or a doctor's report for that death to be classified as COVID. And that's one of the problems with this number that a lot of experts are pointing out, is that if in a normal year only 22% deaths actually have a cause attached to them, during a COVID year it's kind of unreasonable to say that all COVID deaths are reported. The second is obviously our health infrastructure. In many parts of India, I mean even today, the RT-PCR machines, there are many districts with not a single RT-PCR machine available in the district. The antigen tests were not widely available for a large chunk of the pandemic, and testing costs money, and substantial money for an economy of India's size, where average incomes are very low in that regard. So in that sense, that 5.25 lakhs is what I would say kind of a bottom number that has been medically certified, and therefore we should look at it with care and with some level of suspicion.
So is that the only reason for the undercount, or are there other reasons why we could have undercounted, or why the government number seems like an undercount?
So I think it's hard to say, but one of the things also one must keep in mind is death registration itself is imperfect. Not all deaths in many countries are registered. Some deaths that take place at home, the last rites are performed and the government is never notified. So for example, India historically had, up until about 10 years ago, we were, even by the official registration system, in the 60 to 70% range of deaths being registered. That number has crept up steadily over the last few years. And in 2019, the government claims that 92% of deaths were registered. But even then, about 8% of deaths are never registered. And this is only registered deaths. So that's another reason to undercount. And in fact, as I said earlier, the United Nations has a different way of counting how many people would have died in India in a normal year. And that number is about 10-15% higher than the government. So even that would cause this to be an undercount.
Okay. So we'll move on to the other reports. So people have used different baseline, different kinds of data sets to come to their conclusion. One seems to be the civil registration system, and where all data is recorded by the local governments or the state governments. How is this done, and what are the various modalities in that? Could you explain?
So this slide, I just wanted to summarize the fact that there are over 10 studies that estimate excess mortality, some of which are India-specific and some of which are global. So just drawing your attention to the slide, the red dot in the bottom left corner is the official number that the government of India has recorded of COVID deaths. The blue dots all indicate the various different estimates that people have made. And we'll talk about each of these, but just very quickly, the first one, for example, there's a study by the WHO, which uses a statistical model. And there are two kinds of models for different kinds of countries and so on. The next number is from a excess mortality, COVID excess mortality collaborator team out of University of Washington. They have put a paper, they have published a paper in the top medical journal Lancet that estimates that number again at that 40 lakh mark. There is a paper in the Science which relies on a survey and then adjustments to the survey for various statistical reasons. That puts that number again at that 32, 33 lakh mark. That's the third one. There are some modeling studies by the Economist, which is actually a live website that you can visit anytime and see for any country what the estimates are. That's a machine learning model. That's another estimate. So the first first four that I have just talked about, the WHO, Lancet, and the Economist, those three are global estimates. The Science paper is India estimate. And all the other papers on the right are estimates that are India-specific based on various data sets. The key thing to remember is they are by different sorts of scientists. So the WHO paper has a lot of statisticians and mortality and health experts. The Science paper, the lead author, one of the lead authors is a person who studies mortality as a professional expertise area. And the other authors are survey experts that ran the survey in India and so on. In terms of the excess mortality collaborators, there are experts in mathematical modeling and health. In terms of the last three here, the Anand paper, those are economists. Arvind Subramanian is one of the authors. And economists have standard measures and needs for measuring death for various reasons. So they have applied certain methodology. There is a paper in the American Journal of Tropical Medicine. So there are doctors, ophthalmologists who have attempted to do it. So there's a various kind of expertise that has been put forth and various types of mathematical techniques that have been used to arrive at the estimates. So any kind of critique of these numbers that says that the data set was incorrect or the methodology was incorrect or it was not correctly applied, I think any critique of that nature needs to take into account that people with different expertise and different data sets used it and published in reputed journals or made their study available online in a transparent way. So any critique of this, and there may be errors in one or more of these papers, but any critique needs to take into account the whole literature rather than targeting an individual paper. But we'll get into the methodologies on some of these.
Yes, so can we go to the next, the civil registration system and what it does to give us a number?
Right. So the civil registration system is India's system for recording deaths in the country. It's a system that's under the Home Ministry, but is administered at the state government level. So within each state and within each local government body, there is an appointed officer or set of officers responsible for recording deaths. So at the Gram Panchayat or smaller levels, there may be a Gram Sevak or a common government representative to whom a family can go and inform of a death event, and kind of that gets noted down in a physical register. Those kinds of data get aggregated at the taluka level or at the district level and eventually aggregated at the state level. In more urban centers, for example, in Bangalore, there are computerized death registration systems. They may be administered by the local municipal corporation. And the municipal corporation actually, in urban areas in India, it's required for cremation, for example, that the crematoriums will require you to produce a hospital document that says that death was recorded in such and such hospital or by such and such doctor, and then give you a proof of cremation, and all of that will go into the death registration system for you to obtain a death certificate for someone who died. So in the urban areas, the civil registration system is administered by the urban local body. In the rural areas, by the rural bodies. All of this data, each state aggregates. And this aggregation is done throughout the year. So it's not like the data is only made available at a certain point. The data is constantly evolving and getting corrected. So for example, a family may not report a death event for 3-4 months. And then maybe certain things come up, like a property dispute or some inheritance or some bank account, and they realize that we need to register a death. Then they go and register. Well, then that particular death will be reported 4 months later, and so on. So those kinds of aggregations take place. So this data is evolving over the year, but eventually each state certifies how many deaths occurred at various levels, and sends that data to the central body. And that comes from all the different states, is aggregated and validated and then released. So the CRS data is released about 2 years, 1.5 years after the calendar year. So for example, for the year 2020, the death registration data, the official data, was released in early May of this year. And for 2021, which is the bigger pandemic year, the data will be released in about a year from now. But because this data incrementally becomes available from state governments, from municipal corporations, from gram panchayats, there are ways that journalists and data scientists and others have accessed that data. So for example, Andhra Pradesh, I think, has a web portal where you can actually go and download the CRS data as of that day, as of that moment, and use that data. Or certain other states require, you can file an RTI and obtain that data. In certain states, journalists have actually gone to the local body and looked at the death registers, photocopied them, and then counted them, so on and so forth. So essentially, while the CRS data for 2020 was not made available until May of this year, officially through the Home Ministry, nor is the data for 2021 available at all at this point, there are pre-certified or there are earlier versions of the data as the state governments have recorded them that have been available. So what journalists and scientists have done is they have collected that data from as many sources as they could. So for example, many of the studies I pointed to in the previous slide rely on a data set that has between 15 to 18 states of India for which this data was obtained. For some states, it was the entire state, like for example, Andhra Pradesh. For certain states, it might have been some of the big cities or small towns in the state and so on. But essentially, these 15 to 18 states between them have more than half of India's population. So that's a good sample size with respect to a statistical estimation technique. So what many studies have done is they have taken this partial CRS data, which is official death registration data, but prior to verification and certification by the government. And they have said, okay, if X number of people have died in these 15 states over this period, some of that data is for all of 2020, but none of 2021. Some data is available for half the year of 2021 and so on. So different studies have used slightly different data sets, but all of them have essentially done an extrapolation that if these 15 states experience these many deaths, then what would be the reality for the whole country? And these states are not geographically concentrated in any part of the country. The data are from multiple states across India, and that's how they have done it. And obviously, because you're doing a statistical study, there are other adjustments that people have made for the population age, for health infrastructure, or for how much of the sampling, how much weight in the sample that data should get and so on. But after applying all those methods, it is possible to extrapolate from that 15-state data set to the whole country. And that's one way of in which people have done it. And there are uncertainties associated with it. So they have projected a number and they have said this is the uncertainty in the number. But that uncertainty range itself is still multiple orders of magnitude higher. But that's a method.
Yeah, and if this is from the actual numbers that we have got from the various places in the country, we're talking of another method where we are doing a survey of sorts. Now, how does that work and how does that compare with the CRS itself?
Right. So the survey-based method is slightly different. So what happens here is either a survey is done for other purposes. So for example, the private body CMI does a survey, I think every 4 months they release the results. And from that survey, there's a question in that survey about was there a change in the size of your household in the last 4 months? And the change is expressed in terms of deaths. So that survey can be adapted because the CMI reaches a fairly reasonably good sample across the country. And therefore, their consumer pyramid household survey, the CPHS survey, has some data on deaths. Now, there are biases because that survey is known to have a slightly more urban bias, not known to be representative of the country, but that data is available at a 4-month granularity, how many people died. So some people have used that. The National Family Health Survey also has death events recorded. That's another way of accessing data. The most well-known of this is the paper in Science. The private organization Seawater, which does a lot of surveys in India and have a well-established sampling methodology, well-established way of setting up the calls and so on. So they were recruited to make telephone calls every week during the entire course of 2020 and 2021. And the telephone calls essentially involved picking a randomly selected number. India has a very high proportion of telephone penetration. So that kind of gives you a good sense that you can reach a lot of different kinds of people. And they asked a question, was there a death in your household? If so, when did this death occur? And they did that week on week on week for the last 2 years. And in total, they made 1.4 lakh phone calls. And out of that 1.4 lakh phone calls, they recorded the death events. Because the phone number data set is randomly selected and selected on a statistical methodology, they were able to kind of understand how representative their sample is of the country. And based on how many deaths were in that sample, they were able to project for the whole country. And they also validated that result from the CRS information that was already available. So they said, for example, if for the state of Karnataka we have CRS information, then how does our projection based on our survey compare to that information? And they found fairly good alignment. So in that sense, they have done testing to verify their results. And so that method kind of, even though the survey sample may be relatively small, because of statistical techniques, one can make adjustments and kind of come up with a reasonably reliable estimate. So that's how some people have done it.
Yeah, the third one seems to be more medical or science, based thing, the seroprevalence one. Is that, how relevant, or, of course it's relevant, but how detailed is that, and how effective is that in measuring excess deaths?
Right. So if we think about the first two methods, the methods rely on a death event having occurred and then being recorded or being noticed through a survey and then extrapolating from that. This method, on the other hand, this is in the Arvind Subramanian's paper. In this method, they take what is known to be COVID's infection fatality rate. So the idea that out of 100 people that get COVID, a certain proportion of people are likely to die. And that study has been done in other countries. In Subramanian's paper, they refer to the study done in the US. They found a fatality rate, infection fatality rate for COVID. Now, obviously, that was for the first variant, I believe. But they found a fatality rate. They adjusted that for the Indian population, given that our population is a lot younger and so on. That infection fatality rate, they multiplied by the seroprevalence. So seroprevalence tells you out of 100 people at any given time in a given place where the survey is conducted, how many people are going to be infected with COVID. And based on that, you know the infected share of the population, and you multiply that by the fatality rate. So essentially, out of 100 people, if 10 people are infected, then out of that 10 infections, how many death events occur is something that's known because of the disease phenomena. The fact that the COVID virus affects humans in a particular way, and therefore a certain proportion of people die, is known. And from the seroprevalence, we know how many infections were there. So the multiplication of those two gives you an estimate of how many people are likely to die. So while the first two are after the fact, this doesn't rely on actual death being recorded. It simply relies on seroprevalence studies.
Okay, that's interesting. We'll come to the crux of the evening, and I'd like to, stop and talk about your paper here. So it's a very, very different novel and something that nobody else has done. So what made you pick this, life insurance claims as a start point to, understand or to arrive at a number?
Right. So I think as you will appreciate from this slide, that one of the problems or one of the criticisms of many of these studies has been, for example, that a sample of 1.4 lakh phone calls is very small for a country of India's size. Or a sero survey conducted in small chunks of India is not necessarily representative of what's going on across a large and diverse country. Or even the CRS death data, which is only available for about 15 states, which is unverified, which is subject to update, which is subject to verification by officers and so on. So the fact is that these studies have been criticized on these grounds. There has been evaluation of these studies which has said either the data is unreliable, or the methodology is unreliable, or the data is insufficient, and so on and so forth. So by the time we came to our life insurance claim study, one of the things that was sticking in our minds was that how do we get a more potentially representative sample for the country as a whole, We were not, I mean, some of the studies are interested in projecting deaths for individual parts of the country, individual cities and so on, or individual periods of time, how many people died in a particular month. We were not really looking at that kind of scientific precision or that kind of level of granularity. We were trying to cure for these defects, the fact, or these alleged defects of data. So Shekhar is actually a banking and finance professional. So he's been in the insurance industry. He understands that insurance industry actually decides the claims that you pay, the premiums that you pay on a life insurance policy is decided based on mortality tables. Insurance industry estimates what the likely mortality is going to be from the population that has insured itself, and therefore they know how many payouts they're expecting in any given year, and they project that out for the future. So the insurance industry has a financial stake in a death event, because when someone buys a policy, the insurance industry needs to decide or determine how many claims are likely to be filed and how much the payout is going to be, and is this going to be a profitable exercise to insure a group of people and pay out a small percentage of them. So Shekhar had this insight that because the insurance industry is invested in this, and because when the payout occurs, the payout only occurs when a death is confirmed, because there's a financial thing that the insurer is actually writing a check. That means that that death is more kind of certain to be true than, for example, a seroprevalence-based extrapolation, or in a survey you may have a sampling bias and somebody may report a death that did not occur and there's no way of verifying. So that was his insight. That's what made us look at the insurance data.
Yeah, so the other analogy that came to my mind was that when we are looking at GDP numbers, we look at, for that GDP number to pass the smell test, we're looking at proxies such as vehicle sales or industrial production or, any of those indices as such. Is this also a certain proxy for, like deaths, or is it,
In some ways it is, yes, yeah.
So can we now go to the exact methodology that you used to, come up with that number that you have?
Sure. So this is going to be this is still simple arithmetic, but just bear with me as I walk you through very quickly the method. So essentially it had 4 steps. What we first started with is we have data, official data from the government, released by the Home Ministry through the CRS system, of how many people died in India in any given year. This data is available for more than a decade. So first we went and obtained that data of actual certified deaths by the government in a given year. So we know these deaths were registered. So we know these many people died for sure, because this is what the Home Ministry is officially putting out as the number of people that died in India in any given year. So we obtained that information. So that information is that 80 to 85 lakh number that I talked about in recent years, somewhere in that range. So that's kind of the ground truth that we know of number of people who died in India in any given year. Then the next thing we did is we looked at the Insurance Regulatory Authority, IRDAI, puts out a report every year in late November, early December. In that report, IRDAI has a table that says how many total insurance claims which are settled, which means that they are paid out on the event of death, were settled in a given year. So the IRDAI puts out this information by financial year. This is across all the insurance companies. So LIC is the largest life insurance company in India. But even across private insurers, because this is a regulatory authority, they are able to aggregate information from all insurers and put it out. So therefore, we know from looking at annual reports of the IRDAI for prior financial years, we were able to obtain how many insurance claims were settled on event of death in any given financial year. So that was the second data set that we collected. There was a little bit of a problem because the IRDAI report comes out in November. We had data only for 2020. We didn't have enough data for 2021. For 2021, the fiscal 2021 report covers only 3 months. But a fortuitous event occurred, which is that the Life Insurance Corporation, LIC, actually had their initial public offering for share listing. And as a part of making information public, they actually put out information about how many death claims the LIC processed, even in the last 9 months of 2021, which would be in the fiscal year 2022. So we were able to get partial numbers through the LIC data, but we know historically that the LIC has about half of all death claims settled in India are actually paid out by LIC. So for those 9 months, we multiplied the LIC numbers by 2 to essentially say these are how many claims would have been settled. So that was an estimate. So our number for 2020 of how many insurance claims were settled is an actual number from the IRDAI report, adjusted from financial to calendar year. For 2021, our number is an estimate. For the first 3 months, it's an actual number. For the remaining 9 months, it's an estimate based on information that the LIC has put out. Now, once we have both these numbers, the actual deaths registered and how many death claims were settled, we are able to calculate a ratio between the two. Essentially, out of the total people that die, how many insurance claims actually arise that are settled, that are paid out, which means these are verified deaths. And we calculated that ratio and applied it in 2020 and 21. So let me just quickly show you the numbers, right? So I have shown the numbers from 2017 onwards in this table. As you can see, in 2017, we had 64 lakh deaths registered, 2018, 69, 2019, 76 lakhs, and 2020, 81 lakhs. As I said, over the last decade or so, the death registration has improved. So we see these numbers going up. That doesn't necessarily mean that more people died in 2018 than 2017, for example. The fact is that the registration improved, and therefore we got more deaths. And if you look at just that number for 2020, it kind of seems like a simple straight line kind of extrapolation that says every year about 4-5 lakh extra deaths are registered, which indicates improvement in the system. And that's one of the things that the government is saying, that improvements in the system means that we would have expected 81 lakhs to be registered, so we have counted all deaths. But now come to column B, right? We can see that the insurance claims that were settled in each year are also growing in the same period. And we calculated the ratio. So we know that that ratio is at around 24% in each of the pre-pandemic years. The 3 pre-pandemic years, the most immediately preceding years, out of all the deaths that take place, the ratio of claims settled is about 24%. So we know that in some sense there is a stable relationship between how many insurance claims are paid out versus how many deaths take place. So we were able to arrive at that 24%, and we applied that to the claims settled as we obtained from the insurance data. So that's that 21 lakhs in 2020. 21 lakh claims were settled. In 2021, we estimate that 30 lakh will be settled. We know actually from the data that 17 lakh were already settled between the LIC data for the whole year and industry data for the first 3 months. We know that 17 lakhs have already been settled. We estimate another 13 will be settled. So by our calculation, when the November IRDAI report comes out, it should show about 30 lakh death claims settled for the year 2021. So once we had those two numbers, and I'll just chart them out for you, right? So these are deaths registered are in blue. So that number has been growing. But the insurance claims have also been growing. And in fact, if you see between 2020 and 2021, there's a rather sudden jump. 10 lakh excess claims is what we are looking at potentially, which tells you that if that many excess claims are coming in, there's a natural kind of understanding that some proportion of those will be insured, and therefore, or if the proportion of insured that died, if 10 lakh more people have died that had insurance, or claims have been settled, not number of people, then that is bound to reflect in the number of deaths. So this is kind of how we went about it, right? So that 21 lakh number for 2020, we applied that 24% ratio. So we estimated about 86 lakh people would have, 86 lakh deaths would have been registered. So our number, our projection is not what actual deaths are, right? In fact, we are saying that we don't know what the actual deaths are, whether they are United Nations is right or whether the government of India is right. But we know that these many deaths are expected to be registered based on insurance data. So therefore, if we expect about 86.8 lakh deaths to be registered, and the government has only registered 81 lakhs, we believe an excess of 5,64,000 would have died in 2020. That's the missing death registrations that we have. So those should have been registered, those are not there. So in some sense, they are excess because they are likely to have occurred, but they have not been reported. For 2021, that number becomes much more starker. And what happens here is because the count of insurance claims itself is projected to be 30 lakhs. If you divided it by 0.24, you get 1.24 crore deaths. In a normal year in India, we record about 83, 85 lakh. So that's about 39, 40 lakh excess deaths just in 2021 over a normal year. And in fact, that's the number that shows up, that 41 lakhs there. So if we now kind of see all the data together, in blue are the registered deaths and with the trend line. So the trend line shows that the registered deaths has been going up. And that's in the prior years, it's definitely due to improvement in registration. But if you see the same thing in 2020 and 2021, the linear trend falls way below what we estimate from insurance data. And that difference between the linear trend projection and the number is in some sense the excess death count. And that's what we kind of arrived at. So I'm sorry for the kind of detailed mathematical explanation, but hopefully that made things clear. So just to kind of close that out, to put our work in perspective again, our number is fourth from the right here, and it's right in the middle of all the other estimates. It's very close to the WHO number. It's less than the Malani and Ramchandran paper. It's more than the Leffler paper and so on. But pretty much every one of these numbers is 6 to 10 times larger, the official COVID death numbers. And each of these is coming at it either from a different data set, the CRS registration system, the surveys, the seroprevalence-based extrapolation, or from insurance data. So depending on which data set you use, you'll have different sets of uncertainties, different methodological issues that you have to tackle and so on. But no matter who did the study and no matter what kind of extrapolation or modeling was done, the actual estimate still comes out to be 6 to 10 times larger. So this is kind of a question to ask, is that anything, I mean, maybe it is that some of these studies have errors in them. Maybe some of these studies can be critiqued from a methodological perspective or from a data perspective. But anyone who wants to kind of say that what is India's COVID mortality situation should not be taking the government number at face value and say that is, because that's what we counted, that's the true number. In fact, we should look at it critically and say if that many different approaches are giving you different numbers, then engage with them seriously and kind of try to gauge the situation from that.
Yeah, so we critique the government methodology. Now there are there are various critiques of all these papers that the government has put out either through official sources or through various other op-eds that we have read. Yeah, so going with those and what would be your response to each one of them is something I would be interested in. The first critique has been that India has a very robust death registration system. It has improved over time and more than 90% of all deaths are registered in the country. So the claim is that we could not have missed that many extra deaths. So is there another explanation for that kind of a critique?
Right. So I think two things there. One is that 90% plus itself is an estimate. So the government does another exercise, a sampling exercise called a sample registration system, SRS, by which about 80 lakh households are surveyed in every given year and asked whether a death occurred in that household. And from that 80 lakh, which is across the states, there's a projection made of how many people would have died in a given state in a year. And that projection is compared to what was actually registered to arrive at the proportion of deaths that were registered. Because that SRS is itself an estimate and is based on a sample, it's subject to the same kind of methodological problems that are being alleged against all these studies, first of all. The second is that in many states, the SRS number, the projected number from the sample survey of deaths is actually lower than what was registered in that state. So that's a very strange thing, right? You have a statistical phenomena where a survey-based sample is telling you that X people died in the state, but the actual registrations are larger. So there are problems with the SRS methodology itself. So in some sense, India does have a robust registration system, but there are problems with the SRS. The other is the government's own survey, the NFHS survey, the National Family Health Survey, that was done in the same period that covered the pandemic years, actually estimates that only 71% of deaths in India are registered. So by government's own SRS, the government saying 90% plus are registered, but another survey that the government does, the NFHS, actually says 71% are registered. So the robustness, while credible and it's improving, it's unclear whether we are at 71% or 90%. And as the United Nations says, we are not at 90%. Very likely our SRS is undercounting.
Okay. The other critique as such is that you're using partial or unverified CRS. Even if you're using CRS data, you're using partial data, you're using unverified data, that is the data that the union government has not certified as such. So how accurate can that data be?
So as I said earlier, it's unverified, but it's from a government source. It's from a municipal corporation, it's from a state government, it's from some other body that actually handles CRS. So yes, it's subject to update. But one of the challenges in doing these studies is, should you actually then wait for the government to put out all the data? Because as I said, the CRS data for 2020 was just released in May 2021. For 2021, it will be released in May 2023. So by the time we actually use the official data and arrive at estimates, it will be mid-2023, long in the rearview mirror. Whereas from a policy perspective, from a decision-making perspective, it's important that we estimate deaths as quickly as possible so that we can be prepared for future waves, we can kind of have a compensation programs or other activities that can be based on the estimated deaths. So I don't think that critique is very valid, because even if it is unverified, it is from a government source. And if that critique has to remain valid, then maybe the government should release the data quicker and certify it quicker, or say what are the error bounds in the data that it has released quickly. And even then you can kind of still see that the estimates will be similar.
Yeah. The third, I'll come to the other smaller critiques as such, but the third main one is the modeling itself. A lot of criticism has come in saying that modeling techniques do not fit this kind of study and modeling may not work all the time. So, and a lot of these studies have used modeling, right? So, statistical modeling. So how does one counter that, and where is the truth actually?
So I think that's one of the more legitimate ones, that there can be legitimate scientific critiques of statistical methodology or modeling methodology. But for such a critique to be credible, it has to engage with what the actual methodological flaw is. So in some cases, for example, in the WHO's method, there is an assumption that people have objected to, and it seems a valid assumption. But then the onus is on the critique to kind of say, okay, if this assumption were invalid, what would be the range of estimates? What would be the error of estimates? And would that actually substantially push us down towards the official number? That kind of critique has not come out. Second is, because each method uses different data sets and different modeling methodology, the critique that applies to one method doesn't apply to the second method. So in that sense, if one has to engage critically with all these studies, the government should actually have its own experts look at all the studies, methodologies, data sets, and so on, and one by one kind of come up with modeling related issues. And second, I think, these are published in the top tier journals in the world. Science is the top science journal, Lancet is the top medical journal. The Economist and WHO have a reputation, public reputation to maintain. Even people like Arvind Subramanian, who are putting out a draft paper, have a reputation. So all of these people have said, here's what we estimate, and obviously there are a lot of uncertainties associated with it, but we are open to critiques. On the other hand, just kind of not engaging critically and saying modeling itself is not valid as a method, I think is a very not a very credible way of critiquing the studies.
Yeah, the last one that I want to draw everybody's attention is to the compensation scheme. I don't know how many of us know, but the Supreme Court had mandated that the government pay out a compensation to COVID-19 victims. The survivors of COVID-19 victims. Now, the government says that only 5 to 7 lakh applications for this have been received. So it cannot be that we have 50 lakh, because everybody wants to claim, everyone who is eligible at least wants to claim that compensation. Now, if people have not claimed that compensation, it just means that there have not been that many deaths. Is that a valid assumption, or is that a valid criticism against this?
So that's actually a nice example of a circular argument. So the Supreme Court ordered the government to to calculate a compensation per COVID family and pay it out. The government said, we will pay 50,000 rupees to any family that had a COVID death in the family, but that has to be administered by the states, and each state will set criteria. So Maharashtra has a portal for this, UP has a form, Karnataka has a form. Now all of these states pretty much have required that you produce a cause of death certificate that says COVID, right? Now, as we saw, 22% deaths have cause of death reported with it. And to certify a cause of death, you need a medical test of some kind. So the fact that only 5 to 7 lakh people have showed up tallies with the government has certified 5 to 5.25 lakhs as COVID deaths. The others who have not shown up, I mean, first of all, the scheme has hardly been advertised. Not too many people know that such a compensation scheme existed.
Yeah, comparing it with the vaccination drive, information campaign that was on.
Yeah, so I think in that sense it's circular, so it's not very valid to say that. I think if the scheme instead said that if there was a death in your family, let's say in a COVID wave, let's say either in the first wave period or the second wave period of, let's say, April to July 2021, if there was a death, just approach us, you don't need to bring proof because testing was difficult and expensive and so on, and we'll still pay you compensation. Many more claims would likely be registered. So I think the circularness of that argument is there.
We have about 4 minutes more. So we'll just go into, the government narrative around what happened. And the government claims that they were effective in managing the pandemic because of all the mobility restrictions they made, as well as, the oxygen trains they ran, or the PPE dispersal they did, or any of that. So, and the biggest claim that they make is that the Made in India vaccines and the vaccination rates that are in the country did really help with managing the pandemic. So what is it that we are missing in this, from seeing in this narrative? Or what is this narrative not telling us?
I think it's interesting that the government's pursued this, and it's not just the union government. Even the state governments have said this, that we have enforced lockdowns, we have imposed restrictions on inter-district travel, we have carried out zero surveys and adjusted movements accordingly and so on. So I think the government is clearly right that they have done a lot of things to try to manage the pandemic. They have mandated masks, for example, or to board an airplane, you have needed a COVID test for a very long time. So they have tried to control transmission and so on. The key thing to remember there is that those activities need to translate to results. And by kind of having results that are not particularly believable, one can say that the activities were there and they must have played a part, there must have been some benefit to it. But to say that therefore we had the world's best record on per 100,000 deaths, 38 deaths per 1 lakh people, just because we did all this is kind of, I think it's a little problematic because pretty much every country in the world had movement restrictions. A lot of countries in the world have hospital infrastructure with good oxygen and so on. So can the government point to something specific that India did well and actually produce a study that says because we did X really well, we had this? There's no study put out. It's just more of a, we did a lot of activities, so they must have worked kind of narrative there.
More an input-focused thing rather than an outcome-focused thing.
And with regard to the vaccine, I wanted to kind of show this chart. This is from the NDTV website, which tracks daily vaccinations over the time that the vaccination started from. So the area under the curve, the total area, is the number of people covered by a vaccine. So towards the left, you see that is the first half of March of 2021. The vaccination really truly started very small proportion in January and February, but by March people were getting vaccines. But if you see between March and let's say July of 2021, the number of people that have received even one vaccine dose is a small fraction of the population. A majority of the vaccine coverage actually happens starting July to end of 2021. And we have that big peak in September that everybody knows about. But the key thing to remember is vaccination is proven science to protect people from death, right? But the fact that vaccines had not reached most of the population by the time the second wave came in is not something, it gets lost in the narrative. So I've pointed out that that period where the vaccines had reached people was a very small fraction. And in fact, most of the deaths in India from all the studies seem to have occurred in April, May, June, July of 2021. In fact, the WHO estimate of 47.4 lakhs, 29 lakh of that estimate is just in 3 months, May, June, and July of 2021. So in that regard, the fact that vaccination drive has been successful, yes. Going forward, we will definitely benefit from the world's largest and most successful, in some sense, vaccination exercise. But that doesn't kind of work in the past. People don't get protection before they're vaccinated. So in that sense, that's problematic.
So we had kept the last part to discuss what the government should really do in the immediate term. I mean, for me, it's just the compensation thing, that the compensation scheme that needs to be revived. But in terms of data and other things, could you just share some light? And maybe we could go to the questions immediately after that.
Right. So I think that's pretty self-evident that releasing more and better data on time would allow better studies to be conducted. So the government should release data and allow experts to engage with it more critically. The compensation scheme was closed in late May, and that's too early. Only about 5 lakh people filed. So government should look at correcting the compensation scheme, relaxing some of the criteria, making it easier to file claims, advertising it better, and so on, so that people who were actually affected by the pandemic get some relief. The third one is actually from the science paper. And essentially the idea is that the truth will remain invisible if we don't actually have a on-the-ground way of measuring it. So because we have a census that has been delayed and is now going to be carried out soon, one suggestion is to add a question to the census that says, did anyone in a household die in 2019, which would establish a baseline year, and then 2020 and 2021, which are pandemic years. What that would do is it would actually give us a real estimate, because census is supposed to reach every Indian household. We'll get a real count of how many people died. And that will be valuable going forward for pandemic management. And then the last one is, again, a request from researchers, really, that release the 2021 official CRS data so that studies can be made and corrected. And the government should provide the data at granular levels, right? That data, the CRS data, once released, will be available at state levels and so on. But if more data is made available, individual experts or individual cities can actually calibrate how well they did with the restrictions that they imposed or with their vaccination programs and so on. So that's another kind of request.
Yeah, thank you. We come to the end of this section. If any of you have any questions, please feel free to do so. You could come and forward here. You could introduce yourselves and then ask the question.
One is, this LIC claims, the percentage which you are talking about is 24%, can be applied for a normal year. How can you apply the same percentage to an year which has got a pandemic? Generally in the pandemic, it will be much higher. The percentage will be much higher, isn't it? Something like a 34% or 40% it might be. Okay, the pandemic extra deaths which is there, so that might create much higher. So the way like saying that I'm using the same extrapolation of 24%, even for a pandemic year, is not convincing. That's my first question.
So let me answer that before, or maybe you can go to the
Okay, the second question I have is, I agree that the counts might have been missed in the other parts of India, but not in metros. Metros, it's very difficult to escape from the death registration because you have to go for the cremation, right? If I take the death count in the Bangalore, that should give me the real picture, actually. So that may not be so wrong from the government registration. So why can't we use that and extrapolate? That's the way to do, right? Because smaller villages, there is a possibility that they didn't register and they died. Okay, so that could be possible, but that will not happen in a metro like this because we cannot cremate those bodies, right? So those are my two questions. Thank you very much.
Thank you, and excellent questions both. I'm not sure I'll be able to do justice to both, but I'll try. So I think the first question is very reasonable, that if in the pre-pandemic year, if death registrations are 24%, insurance claims are 24% of the death registrations, is it valid to apply the same ratio? So that's precisely the definition of excess deaths, sir. So if you think about a non-pandemic year, right, the number is stable at 24%. So if 2020 and 2021 were non-pandemic years, we would expect that ratio to stay at that 24% mark. And therefore, we could multiply the insurance claims by 24% and arrive at what the death registrations would be. Now, what our goal is to calculate excess, right? So the goal is, again, if you go back to the definition of excess mortality here, right, the idea is to compare the observed mortality with the expected mortality, and that would give you the excess mortality, as this formula says. So if I apply the 34% or whatever number, right, first of all, I have to take in non-pandemic year, like 2017, 2018, 2019, see what phenomenon were in place. I know that phenomenon is 24% is the ratio of death claims settled to number of deaths registered. Presume that in 2020 and 2021, that phenomenon in a non-pandemic situation, if 2020 and 2021 were non-pandemic years, that phenomenon would hold true because there would be no necessary underlying reason for it to change. So if I apply that 24%, then I would get the result, right? The problem, the effective thing that has essentially happened is that because that number has been 24% year on year, but the death claims settled have jumped dramatically, right? That number, if I say that number is 34% of the deaths, then the 34% of the actual death registrations, then I am basically saying that for some reason, the insured people suddenly started registering deaths much better than they were doing in the earlier years.
Age is much higher. Quite possible.
It is.
Natural death. So the number of people who will be going for the insurance will be naturally very high because the age of the person who died is much lesser compared to the previous years.
So that
You cannot compare, use the same percentage for both years. I'm so sorry.
No, I think the point you're making is that the cohort of people that died of COVID is disproportionately older people die of COVID than, let's say, younger people and so on. And so therefore, and you are saying that the older people are likely to have insurance, right? So I think 2 points there. One is that life insurance is actually bought by a lot of people in their working age because it's an insurance policy against the death of a wage earner in the family or so on and so forth. So the number of people who are insured at a younger age is also very high. It's not that only older people are insured or only older people file. In fact, in accident cases, younger people will file and so on. So I think it's not easy to explain, but the basic idea is that the insured people dying, suddenly there is no reason to expect that the insured people died at a 50% greater rate than they died in previous years. While older age is feasible, is one explanation, there is no reason to believe that would lead to that much of a jump, especially in India, where the younger share of the population is much, much larger than people 60 plus or 70 plus. The sheer number of people 60 plus or 70 plus in India is relatively smaller. So while your question is right, I would answer that by saying one is the number of older people is smaller. Second is that for any objection of this kind to hold water, the 50% jump year over year in insurance claims cannot simply be explained away by elderly deaths. Remember, the difference is again that we are estimating 47 lakh excess deaths. The government is registering 5 lakh COVID deaths. If, let's say, instead of that 24%, we used a different number, even a smaller number, whatever number we use, we would still arrive at an order of magnitude larger number than the government's number. And in fact, for any criticism of this to hold true, one would have to look at the insurance claim patterns. And I'm hoping that maybe the IRDAI or one of the insurance companies will actually release age-wise data of the number of death claims settled. And maybe we'll have the answer that way. But without that data being presented, it's very hard to believe that an explanation of this kind would account for all of it. Maybe it would account for 20% of the difference potentially. But even then that leaves 42 lakh excess deaths. So that's kind of my answer to that. There was a second part about the registration in the city.
I'm not convinced with your methodology.
That's your prerogative, sir, and we can discuss offline after the event also. But let me answer the second part of your question. And I'll answer it with an anecdote. Right? So you're right that in cities it's very hard to get cremations if you don't have a death certificate and so on. Among my own family and friends, there are people who could not find a hospital bed in a big city like Delhi and actually went out of state into rural parts of Haryana or rural parts of UP for medical care. Now, luckily, in this particular instance, the person I know survived because they got oxygen and they were lucky. But they saw that a lot of people from Delhi that had actually registered at this unlicensed medical facility outside of Delhi, 70 kilometers outside of Delhi, died in that state, in Haryana or in UP. A lot of people died outside of hospitals that in cities that otherwise would not have died. Hospitals, registration systems, doctors, everybody was overwhelmed to expect that the performance of our cities, registration mechanisms, hospitals and doctors in a pandemic situation where a lot of deaths occurred in a very short 2 to 3 month period, the number of deaths that occurred was very large, to expect that they would continue to actually have very methodical processes and have 100% registration, I think is a little bit much. The second is obviously cremation is an activity that needs to take place within a certain amount of time after death, especially when you don't have the infrastructure to handle all of that. So because of that, again, a lot of registrations could potentially have been missed. Now, whether that is, how much that is in cities, well, hopefully we can find out when the data comes out, when the census happens and so on. Thank you.
Hi, that's a good research. My question is about the Supreme Court compensation. You said it's not reached a lot of people. Even I wasn't aware of this. Most of these schemes start in the center but doesn't reach down south. So how to make it possible, how to make this awareness, how to make this information or this crucial information reach to the people down south?
I think it's a great question. So, in fact, when I became aware of this, so what happened is there were petitions in the Supreme Court that COVID deaths are occurring and families need relief, and the Supreme Court took notice and essentially issued an order to the government that design some sort of compensation scheme with fixed criteria, with fixed payouts, and so on, and launch it nationwide. Now, obviously, because this is a nationwide scheme, the central government let individual state governments decide on it fixed the remuneration or the compensation at 50,000 rupees per death. But obviously, the administrative mechanisms in India all exist in the hands of state governments. So individual state governments have administered it. So Maharashtra has a portal, Karnataka and UP have a form, and there are other mechanisms. I think, like with any other government scheme, without advertising, without public messaging, without an SMS that says, if there's a COVID death in your family, come here and register it, it was very hard for people to notice. Unlike, for example, the mask mandate or the fact that you should sanitize your hands, which every time you placed a phone call, you were told to do these things. And that message reached everyone. I think the best way for a compensation scheme would be, again, to advertise it widely like many of our other schemes are. But other than that, I don't really have an answer. And unfortunately, the scheme was closed on May 23rd. And hopefully, there will be public pressure because there are a lot of families that haven't been able to apply. And maybe the scheme will get reopened. Thank you.
So, probably slightly opposite to what, from a data perspective. So you said the estimation. Okay, I'm Ashwini, and very interesting viewpoint, very interesting way of analyzing from a different perspective. The 30 lakh odd number that you came up from the insurance, likely the insurance claims, and then putting a 0.24 and all that stuff, right? One more interesting perspective. So these 2 years, right, when we had the sizable period of lockdown happening, mostly across the nation and state-wise also, I would say maybe about 15-20% of the year, or maybe at least more than 10% of the year, that we had a complete ban on nothing doing outside. No travel, no highways, no trains, no drives and all that, right? Don't you think that would have reduced the number of accident deaths that would have occurred in that period, right? And corresponding insurance claims and all that. I don't know how much portion, but then we had sizable portion of 2 years, maybe 2 months or 3 months or whatever period, when the number of accident deaths would have reduced. Now, despite that, if you have 10 lakh more, I don't know, how do you put that in perspective and throw some light on that?
That's a great question, actually, because that kind of puts into perspective how difficult mortality estimation is. Because while the COVID risk increased and therefore we expected higher number of people to die, the risk from accidents reduced, or the risk from other respiratory infections or other infections that one might catch also reduced because we were all at home, locked down and so on. So in terms of excess mortality estimations, the phenomena goes both ways. Now the thing too, I would say there are two parts to this question. One is, yes, the deaths due to these other causes reduced, and in fact there is data on number of accidents was much lower in the lockdown period that is available. But one has to look at how much proportion of all deaths in India is accidents. And it's a relatively small number. And then the other part of it is that our estimate is different for 2020 and 2021. In fact, a majority of all the estimates, not just ours, we estimate about 41 lakh excess in 2021. WHO estimates about 39 lakh excess in 2021. Many of the other estimates, the second wave seems to have been a lot more lethal than the first wave. We also saw that in the news and in actual on-the-ground calls for help and so on. So in that regard, there was not as much of a lockdown effect in 2021. We never had in 2021, by my recollection, an official complete lockdown of a state or of the country. The complete lockdown was mostly in 2020, from the end of March to the end of May. But in 2021, we didn't have as much by way of movement restrictions. So it's a confounding factor. And I think some of it would have reduced insurance claims and some of it may have increased. But as a whole, because this number, the 41 lakhs we came up with, is actually half of all deaths in India in a normal year. That is a very, very large number. Accidents are nowhere close to that in terms of what the size is. So I don't think it kind of impacts it that dramatically.
My name is Shubroto Mukherjee. Thank you for this wonderful and very enlightening discussion. So I Googled the fraction of the Indian population that actually has life insurance, and multiple hits gave me the number 3 out of 100, so about 3%. So on the face of it, it seems to me a little strange that while only 3% of Indians have life insurance, about 24% of registered deaths result in life insurance claims. Now, you might think that one reason for this could be that maybe deaths are not properly registered, especially among that fraction of the population which doesn't have life insurance, perhaps for socioeconomic reasons. But then you also mentioned that the registration of deaths in India is not particularly inefficient. I mean, it may not be 90%, but it might be 71%. And you would think that if you have that kind of efficiency, you can't really explain this discrepancy of a factor of 8 from, using that argument. Also, I realize that people might have more than one life insurance claim, but even that doesn't seem to be able to explain a factor of 8. So, do you have any explanation?
Yeah, so two things. I mean, one is I ran the same Google search, and I think that 3% number is itself quite doubtful. Because it's not clear, there is no data available. All the IRDAI reports, this was a number I looked for, whether we can get an estimate of how many insurance policies are there in India. That number, unfortunately, is not available. So first off, that 3% itself is unclear that that's true. The second is, a possible explanation is that may be the retail policies that individuals buy in a given period. Maybe it's the number of policies that are sold in a year or that mature and so on. But we should remember that a large proportion of Indians are also insured under group policies that either come from being a government employee or from being a private sector employee where the company offers a group insurance policy and so on. So between the individual and group, the number is bound to be much larger than 3%. The second part of it is that, yes, it's a sampling question. If only 3% of the population is insured, maybe that's a very small sample. But we are relying not on the actual number, we are relying on the ratio. So even if, let's say, the 24% registrations correspond to only 8%, let's say there are 3 claims per death because of individual and group policies and so on, that number is stable year over year. If more policies are sold or less policies are sold, that number would potentially change. But we found that in 2020 and 2021, according to the IRDAI, the total number of policies sold was not very high. So in effect, the total number of policies that were in force in 2018 or 2019 was very similar to the number of policies in force in 2020 and 21. So in other words, the number of people who had insurance did not change materially. It was not like a pandemic arrived and suddenly everybody went and bought insurance and therefore the claims went up. That did not happen because people just did not buy insurance. That many people did not buy insurance. The number of insured remained the same. So in that regard, there is no reason for the claim counts to go up dramatically. But your question is right, and I hope that we can get data on how many policies there are out there.
Hi, Mihir and Suman. So yeah, I'm their colleague. My name is Anupam Manur, and I work with them at Takshashila Institution. So thank you for that uplifting and wholesome talk on the evening. So I just had a couple of questions. One is to do with really the consequences of miscounting, not reporting the deaths accurately, right? One is the compensation bit, which I think you spoke about, but the other bits could be related to, I would say, I mean, the amount of expenditure on public health going forward, for instance, right? So any thoughts on what is that larger picture consequences of not reporting this data correctly, right? And I think this goes beyond just, the COVID deaths. COVID deaths obviously was an whatever black swan event, happens once in this thing, and everyone is caught aware. But the trend is quite clear, right? We've not released official unemployment data for the last 5 years. There's the employment survey, which we discontinued, which we deliberately discontinued. So I think there's a trend of hiding data, and this seems to be on par for that. So I think any kind of corrective measure or saying, we will look at this and release correct data can have good consequences in that thing going forward. So yeah, just your thoughts on that. Second, this is probably a trivial thing and really, but going ahead, when the CRS data is verified, etc., they will have to look at the excess death, right? Whether it's attributable to COVID or not. So there is that number that will come out, which is then excess to whatever is normal. And at that point of time, they will have to give some sort of explanation. So, I mean, this doesn't seem to be a very well thought out long game, right? I mean, in terms of suppressing data. So just your thoughts on those two things. Thanks.
Thanks, Anupam. So I think I'll take the second one first. I think the moment of reckoning is in the near future. There are multiple data points that are coming out. So very likely the IRDAI data will come out in November, as I said. And our number of 30 lakh claims will be put to test, right? The reason kind of that number is unlikely to be, I mean, for example, we already know that 17 lakhs is an actual number that I have seen in the IRDA and LIC data. So 17 lakh death claims have already been received. So if you look at the prior years, right, in this table, in the year 2019, entire year, 18 lakh claims were received, right? And in 2021, for the first 3 months, all companies, and for the last 9 months, just LIC, 17 lakh claims have been received, which means that even if our number is off by a little bit, let's say that 30 lakh falls to 28 lakhs because LIC's numbers are likely larger and maybe the private insurers don't report as many claims, that number is not going to fall down to the 17, 18, 20 lakh number in the previous years. So I think that's the first test that the numbers will be put to potentially. Another is that the CRS data for 2021 that was used in most of the studies ran only up to about May, June, July of 2021. And deaths are registered with a lag. As I said, 3 months, 4 months, there can be a lag. But as more and more states certify their data or make it available, more RTI happens, the CRS 2021 picture will start becoming clearer. And again, we'll see whether the numbers that are being estimated start seeing in the CRS data. Now, obviously, a malicious state could decline death registrations to people, but I hope we are not in that world. So we'll see what happens then. And by May of 2023, another year from now, we'll actually have the full CRS data released. And that will allow all of these studies to be put to test. So yes, I don't see a long-term game other than potentially kind of saying that continue denying it because all of these are models, all of these are estimates, all of these are based on partial data. Continue that story because that sounds reasonable to a layperson. That sounds very reasonable that you have partial data. And then maybe once the data comes out in a year from now, the pandemic is in the rearview mirror and not too many people are thinking about it. But I don't really know what will happen. Regarding your first question, I think that's a key one, right? The fact that our health expenditure as a percentage of GDP is very low for a population of for a country of our size and health issues, that needs to change. And that has historically across various political parties or alliances ruling state governments or ruling union government, has not changed dramatically. Our health expenditure is quite low. And a jolt like this, the fact that 50% excess deaths occurred in a year or in a 2-year period, just because of one unknown virus, where a lot of people in other countries have been saved through simple measures like making oxygen available or greater availability of ventilators or a better public transportation system that doesn't put you in close contact with everyone, a better housing system for migrants that doesn't put them 10 in a room, all could have saved lives. But for all of that to happen, our public health expenditure needs to go up. And this kind of jolt being recognized, a higher 50% higher number, would have made that politically feasible or would have made that a demand from the population that creates pressure on the government. So my hope is that in a year from now, if these numbers bear out and if the estimates are registered, maybe there will be pressure on both state and union government to increase health expenditure and also to direct it better, to actually undertake reforms in the healthcare sector that allow better healthcare to reach more people.
Thank you all for being here. Thank you for making time on a weekday to come here. And let's hope that we all remember this and we ask questions of the right people. That is one takeaway definitely for me. So thanks. If there are any closing comments.
Thank you. Thank you very much, everyone, for taking time on a weekday and being here and listening patiently. And thanks, Suman, for hosting. And for many thanks to BIC for taking up this important topic for discussion. I hope it kind of triggers further questions, further discussion at various levels of our society. Thank you.